Today, we're jumping into a really core topic in orthopedics: limb amputation and prosthetics. We're going to explore the decision-making, the surgery itself, and the long-term management that really reframes this whole procedure, not as an act of removal, but as the first step in a complex reconstruction.
So, here's our roadmap. We'll kick things off with the why, the indications for amputation. Then, we'll dive into the surgical principles, which are all about creating a functional residual limb. After that, we'll talk post-op care, get an introduction to the world of prosthetics, and then we'll wrap it all up with the key take-home messages.
Okay, first up, the indications. It's so important to understand that amputation is a definitive end-of-the-line procedure. It's the option we turn to when saving the limb is just not possible, or, and this is key, when salvaging it would actually leave the patient worse off, with less function and more pain. When you look at this list, you're really seeing 5 very different roads that all lead to the same destination. You've got catastrophic trauma, where the limb is just beyond repair. You have aggressive cancers that need a wide lateral resection. Then there's deep, stubborn infection, like a chronic osteomyelitis that just won't clear. And of course, the vascular causes: critical ischemia, where the blood supply is gone, and the devastating endpoint of a diabetic foot with sepsis or necrosis. Different pathologies, same tough conclusion.
All right, let's move into the operating room. The whole mindset around amputation has shifted. It's not about failure, it's about reconstruction. A surgeon's job isn't just to remove the limb, it's to meticulously construct the biological foundation that's going to interface with a prosthesis for the rest of the patient's life. So, these 4 goals are totally intertwined. Number 1, you've got to get clean margins. All the dead or infected tissue has to go, period. 2, you save every bit of useful limb length you can. Why? Because every centimeter is leverage and control for the prosthesis later on. 3, you have to create a durable, well-padded soft tissue envelope. This is what's going to take the pressure. And finally, you put it all together to plan the amputation level, balancing blood supply, soft tissue quality, and what you expect the patient to be able to do.
And this right here, this is the end game of the surgery, creating what we call a prosthesis-ready stump. This is so much more than a healed incision. It's an engineered biological part. It has to be painless, shaped just right for a socket, and tough enough to handle the daily grind of walking, running, and living with a prosthesis.
Now, when the patient leaves the OR, the work is really just beginning. That immediate post-op period is absolutely 100% critical. This is where we build the bridge from the surgical event to getting that patient mobile and back to their life.
And this is a multi-front war. Of course, infection control is paramount. But at the exact same time, we're aggressively managing swelling and shaping the limb with compression. We're fighting to prevent contractures, which can make fitting a prosthesis impossible. We're desensitizing the stump, strengthening all the surrounding muscles, and getting the patient ready for the first steps of gait training. It all happens at once. I have to really hammer this point home. Getting the prosthetist involved early is a non-negotiable part of modern amputation care. Their expertise is vital, right from the surgical planning phase through all the post-op shaping. This kind of team-based, interdisciplinary approach is one of the biggest predictors of a good outcome. It's a huge deal. Okay, let's shift gears and talk about the technology. Prosthetics is this amazing intersection of clinical medicine, material science, and pure biomechanics. And it's all aimed at one thing: replacing lost form, but more importantly, restoring lost function.
Now this slide shows you the hierarchy of what matters. On the right, you've got all the cool high-tech components, the feet, the knees, but on the left, that is the absolute priority, the socket fit. You could have the most advanced microprocessor knee on the planet, but if that socket doesn't fit perfectly, if it's uncomfortable or unstable, that expensive knee is worthless. The socket is everything. It dictates comfort, control, and whether the patient will actually use the device long-term.
So once that socket is dialed in, then we can pick the right components for the patient's specific needs. For a really active person, that might be a dynamic response foot that actually stores and returns energy. For someone needing more stability, it might be a microprocessor knee that can prevent stumbles. It even includes thinking about the other leg, like making sure we manage a flat foot on the other side with an orthotic to prevent future problems. It's a whole-person approach.
And just looking ahead a bit, we have to mention osseointegration. For certain patients, this is a game-changing technology that skips the socket completely and anchors the prosthesis directly into the bone. It's not for everyone, but for the right candidate, it's incredible.
Okay, we've covered a lot. Let's really distill this down into the high-yield concepts, the things you absolutely need to walk away with through your clinical rotations and your exams.
So here they are. Number 1, change your mental model. Amputation is reconstruction, not ablation. Number 2, the surgical bullseye is always that prosthetist-ready stump. Number 3, you simply can't succeed without early and intensive rehab from a whole team. And finally, number 4, when it comes to prosthetics, the mantra is socket, socket, socket. The fit is king, and the components have to be chosen for the patient in front of you.
And I'll leave you with this to think about. As technology like osseointegration gets better and more common, how is that going to change the very definition of a prosthesis-ready stump? I mean, if you don't need a socket, what does the surgeon need to build? That's a question for your generation of surgeons to figure out. Thanks so much for joining me.